So where have we gotten now? We talked about the heart as a pump. We've given it a conducting system so that now the contraction is coordinated, right? So we get atria contracting, ventricles contracting. And we talked about the cardiac cycle. Honestly, of the last 3 days of conversation, that graph that has the ventricular pressures and volumes along with the EKG and the heart sounds, that remains like one of the most important pieces we've talked about, because what we're going to do now is we're going to connect the heart ejecting blood, and we're going to create a cardiovascular system out of that, right? So heart has to do its job in order to move blood around the body and deliver oxygen and metabolites and get rid of waste products, okay? So we're going to talk about blood flow. That's where this next chapter gets into. The circulation, in other words. We don't have a proper cardiovascular system until we have blood moving through the tissues of the body. All right, so first off, we really have two circulations. They both meet at the heart. So remember, the heart's a four-chambered pump. It's a parallel pump. In other words, it pumps to the lungs and it pumps to the body, right? So we have two circulations, a systemic circulation that's from heart to the body and back. Pulmonary circulation is heart to the lungs and back, all right? So the systemic circulation goes from the left ventricle to the right atrium. The pulmonary circulation goes from the right ventricle to the left atrium, right? I think that should all make sense. We have some pipes, for lack of a better term, that carry this blood around. And the pipes have different characteristics depending on what the body needs them to do. All right, so arteries are our high-pressure transport vessels. They're going to move blood very quickly from the heart out to the tissues of the body. Now, because they're under high pressure, they have to have thick, strong walls. Otherwise, the walls would blow out, right? So when you look at an artery, you'll see that arteries have thick, almost rubbery, in the anatomy lab, walls. The velocity of blood, in other words, the speed at which blood is flowing, is very fast in the arteries, okay? So this is why, an arterial injury causes blood to not only go a great distance, but it causes bleeding to occur very rapidly, right? Because you've got high velocity blood flowing. Arteries arteries branch. So we start with the aorta, and then from there, the arteries branch and get smaller, and of course they all get new names, right? So you're going to love that later in anatomy. Eventually, the arteries have branched enough and are small enough where they're not really arteries anymore. They're what we call arterioles. So if you think of the aorta as the trunk of a tree, all right, the arterioles are the little stems of the leaves, right? So they're the tiniest little bit of the arterial system that's still just conducting blood from one place to another. All right, so the arterioles are the last branch of the arterial system. And of all of cardiovascular physiology, the arterioles actually play the biggest role. And the reason for that is they can change their size quite dramatically in response to tissue needs. It's the arterioles that are the valves that control where blood goes in the body. We can't open all of our arterioles at once, because if we did, our blood pressure would be like 40/20, and we'd be dead very quickly thereafter. So what that means is only some parts of the body get really vigorous blood flow at any given time, right? It's just those parts of the body change. After a big meal, the digestive tract gets a lot of blood flow. When we're out for a jog, our skeletal muscle gets a lot of blood flow, right? So the arterioles do this by changing their size. And because of a very important physics principle that says when a pipe gets smaller by half, its resistance goes up by 8 times 8. So it's to the third power. We'll talk more about that in a minute. But it means that a small change in size makes a big change in resistance and therefore blood flow. So our entire cardiovascular system controls itself through tiny little vessel size changes. Okay? The arterioles are the primary source of what we'll call TPR, total peripheral resistance. This is the total amount of pressure or resistance to blood flow that the body has present at any given time. Okay? I'm going to put a pin in that idea, but that's where arterioles play a role. More on that later. Now, arterioles end in capillaries, more specifically capillary beds. Capillaries don't work by themselves, they work in groups. Capillaries are utterly tiny vessels. They're so small that red blood cells have to bend and squeeze to go through. Okay, so capillaries are the tiniest of the vessels, but they also have the largest surface area. In other words, if you took all of the capillaries and put them in one big bundle, that bundle would be far bigger than any other artery in the body. Okay? So, and that's there on purpose. The capillaries are there as the exchange surface. Why do we have a cardiovascular system? To deliver nutrients and pick up waste products. Well, how do we do that? Across a surface, right? So the bigger the surface area, the easier capillaries can do their metabolic exchange. We're going to spend a whole lecture talking about that, about how capillaries work. Now, from there, things get kind of less interesting. Capillaries join together to form venules. Venules are like itty-bitty tiny veins. Venules come together to form veins, and then small veins come together to form larger veins, and so on. All right, veins, number one, they are a low pressure, low resistance pathway for blood to come from capillary beds back to the heart. For reasons we'll talk about in a minute, by the time blood leaves the capillary beds, the blood has lost almost all of its energy. So if we're going to get that blood back to the heart, we need to give it a nice, smooth path to get there. That's what veins evolved to do. So when you look at veins, like in the anatomy lab, you'll see that they're relatively thin-walled because there's almost no pressure in the venous system. And they're good-sized. They're bigger than the arteries that travel with them. And the veins have very smooth insides to allow a very low resistance pathway for blood. Now, another thing that veins do, if you look at where is the blood in the body at any given time, 2/3 of it is in the veins. Why? Because the veins are bigger than the arteries. You've seen that in the anatomy lab already. Okay, so if most of the blood is in the veins, any change in the size of veins is really going to shift where blood is in the body. So veins work as a kind of dynamic storage site for blood. When the human is at rest, like you all are, your veins are kind of big and dilated because the body doesn't really need to be actively circulating your entire blood volume while you're sitting there taking notes, right? Okay. Now, if you were to get up and go running up and down the stairs, well, your veins would constrict a little, and that would push more circulating blood into the active side of the system, into the supply side, and would effectively deliver more blood to your tissues, all without the need of a blood transfusion, right? So I call that venoconstriction. When veins constrict, the primary goal there is to push that blood somewhere else, i.e., into tissues that have a higher need for it. Again, more on that as we go through. Okay, so schematically, this is what our circulatory system looks like. We've got our pulmonary circulation here that goes from right ventricle to left atrium. systemic circulation here that goes from left ventricle to right atrium, right? In between, we go from our aorta, okay, to arteries, to arterioles, and then to capillary beds, then to venules, veins, and eventually back to the IVC, inferior vena cava or superior vena cava. We can also see here that, in the systemic circulation has 84% of the blood at any given time, pulmonary circulation 9%, heart 7%. So what does that tell you? It tells you that we got a lot of pipes. We got a lot of pipes on the systemic side. So at any given time, most of the blood is in the systemic circulation, specifically in the systemic circulation that doesn't include the heart. The pulmonary circulation has a relatively small amount of blood, but it only really has one purpose. The pulmonary circulation evolved to pick up oxygen from the lungs and deliver carbon dioxide to the lungs. So even though the amount of blood in the lungs is relatively small, it is still sufficient to supply all the needs of the body. And then we have the veins, venules, and sinuses. We see that down here, okay? And there's that 2/3 I was talking about. So at any given time, 2/3 of the blood in your body is in the venous system. So a small change in that volume can make a big change in active circulation. Now, the easiest way to think of this moving blood around thing, we cannot have all of our capillary beds open at once, all right, because we frankly don't have enough blood for that. That's what we call shock, or it's one version of shock, is, let's say somebody has a bacterial meningitis, for example. All right, so their body, all over their body, their capillaries are dilated from inflammation. Have you talked about inflammation in MedPath? Okay, so vasodilation is part of that. Well, in a systemic bacterial illness, what the body's making a mistake because it's trying to dilate all of the capillaries everywhere. Why? Because it doesn't know where the bacteria is and appears to be everywhere. So what we see in our patient is more and more capillary beds are open and the blood pressure goes down and down and down. Now, as your blood pressure gets low enough, there stops being enough energy to actually move blood around the system. So we end up with low blood pressure and poor perfusion. So that's an example of what happens if all the capillary beds are open at once. So clearly we can't have that. What the body seeks to do is open the capillary beds that are busy, right? That are actually doing something to sustain homeostasis. And as long as there's sufficient blood pressure, then that system that I call autoregulation, all right? In other words, the capillary beds are going to manage their own blood flow. As long as the heart is providing blood pressure, then we will have sufficient blood flow. Okay, so that's sort of the big picture. We'll get to all the details at this point, probably next time. All right, so cross-sectional area. This is a comparison looking at how big the pipes are. All right, so the aorta, being just one vessel, it's easy to measure. You can just look at it. The cross-sectional area, in other words, if you cut the aorta from top to bottom and you look at how big is the circle, it's about 2.5 centimeters squared. All right, so what's interesting is the entire cardiac output goes through that little tiny vessel. Okay, so stop and think about that for a minute. You think the blood flow through the aorta is fast or slow? Fast, because you got a bunch of blood going through a small space. The way I like to think of this is it's like a rapids in a river, right? You've got a lot of water going through a really small space. So the speed goes way up, turbulence goes way up too. All right, now as we start to branch out, we see that the cross-sectional area not just goes up, but goes up pretty dramatically. So if we take all of the small arteries in the body and we compare it to the aorta, all of the small arteries have a 20 square centimeter area versus the aorta is 2.5. So you think blood's getting faster or slower? Slower, very good, quick. All right, we go from arterial, same thing, now we're bigger yet, slower yet. Then when we get to the capillaries, we get this huge jump up. And the reason is because we have lots and lots more capillaries than we have arterioles. So when we go from arterial to capillary, it's like going from a busy river to like the Mississippi in Quincy, Illinois, right? Where it's a mile wide and barely moves, right? So that's the capillaries, huge cross-sectional area. That means blood flow through the capillaries is really fast or really slow? Really slow. This is a good thing. Slow-moving blood has a lot of time to transfer stuff, right? Okay. Then from there we go back up, venules. So things are going to get smaller and speed up, like the cross-sectional area gets smaller, so blood's going to go faster. And then we get all the way to the vena cava. Notice that's the plural. So the inferior and superior together have a cross-sectional area of about 8 centimeters squared. So it means that blood leaves the heart really fast, comes back to the heart quite a bit slower, and has some really slow times in between as it goes through the capillary beds. That cross-sectional area change creates this change that we're going to talk about next. All right, so what we have in our chart here is, so this is time, or sorry, rather not time. This is moving through the vascular system from left atrium to capillaries, from capillaries back to veins, and so on. Okay, so this is pressure. So if we look in the left atrium, what we see is we see an oscillating pressure, but at a relatively low pressure. The left atrium doesn't have much blood pressure to speak of. It generates a little bit when it contracts, right? That's these little tiny peaks that we see. But as I said the other day, atrial contraction is really kind of pathetic. It doesn't actually move very much blood around. So the tiny little pressure increase we see here, that's the atria contracting. Now, if we move across the atrioventricular valve into the ventricle, now we see big old pressure shifts, right? We go from left atrial pressure all the way up to systolic pressure and back again. So in the left ventricle, we get our biggest swings in pressure, right? And that's because the ventricle is the pressure-creating organ, right? So we see the biggest change there. I ask you in the notes here, can you identify the isovolumetric contraction point? That's this steep area, right? When the heart is just beginning to contract before any valves open, that's isovolumetric contraction. All right, so in the left ventricle, up and down. So like if you had a pressure meter in the left ventricle, every time the ventricle contracted, you'd get systolic pressure, and then when the ventricle relaxed, you would get almost zero. You'd get left atrial pressure, which is very, very low. Okay? Now, if we move into the aorta, now we're into familiar territory. At the top end is our systolic pressure. At the bottom end is our diastolic pressure. This is the blood pressure you measure with the cuff in the clinic, right? So in the aorta, we have the diastolic, systolic, diastolic, systolic. Now, as we go from aorta into smaller and smaller arteries, we see that the pressure drops off. Now, the main reason the pressure decreases here is because we're dividing and dividing and dividing. So we're taking the same blood and we're putting it into more vessels, right? Because as you've seen in the anatomy lab, you get all the arteries divide and divide and divide. Well, as they divide, there gets to be more and more vessels, so we're putting the same amount of blood, the blood from the aorta, into more and more vessels. So we get a decrease in pressure as we go from aorta to the large arteries, to the small arteries, to the arterioles. You notice, though, we still have a pressure, a pulse, right? We have a high and a low, high and a low. We don't really lose our pulse pressure, which is what we call that, until we get to the capillaries. Now, once we get to the capillaries, Because there are so many of them, again, we've taken our blood and we've put it into a lot of smaller tubes, the pulse goes away and we get more of a linear flow. So in the capillaries, we have a constant pressure, non-pulsatile, but continuous flow. So blood moves slow here, not fast, but slow. And then in the veins, if you look at the veins here, we have a very low pressure, particularly compared to like systolic, but it isn't zero. Like if you very carefully drew a line across here, zero would still be about right here, significantly below where the veins are. That's critical because what brings blood back to the right atrium is pressure. Like that, it still is a pressure gradient driving it. It's just a much smaller pressure gradient than we see in the arterial side. And that's fine because veins, number one, there's lots of them. Number two, they're very low resistance. So it means that even a tiny little pressure gradient is enough to drive blood back to the heart so that it can be repressurized and go around again. Now, in my chart here, we come through the right atrium, right? Now we're going to go into the right ventricle. So we still get a big pressure change, not nearly as big as the left ventricle. And the reason that this is quite a bit smaller is the right ventricular pressure is only about a third of left ventricular pressure. And that's because we have a lower pressure, lower resistance pathway to the lungs. But we still see the same pattern, which is big swings in the ventricle, smaller swings in the pulmonary arteries, smaller yet in the arterioles, then disappears capillary venules, veins, and back to the beginning. Okay, so we have our sort of pressure differences as we move from one side of the circulation to the next. All right. So ultimately, our goal in our building of the cardiovascular system here is we need to get blood flow to the tissues that need it. Okay? So what that means is we have to move away from treating and looking at the cardiovascular system like it's all doing the same thing all the time, right? Because of course it isn't. Now, the heart is, we only have one heart. It can only do one trick, which is contract, push out blood. And then we have our vessels. They can really only do one trick too, which is get smaller or get bigger. In other words, they can vasoconstrict or vasodilate. That's their only tool. So if we're going to take blood from the heart and get it to where we need to have a way for tissues to control the amount of blood that's flowing through them. Okay? The way that tissues control that is through the arterioles. When the arterioles are in a region that is busy, okay, and I'll define busy in a minute, but when the arterioles are in a region that's busy, they dilate. By dilating, they reduce their resistance, and the blood flow through them increases. Now, how do the arterioles know if a tissue is busy? Based on temperature, pH, oxygen, and CO2. All right, it goes like this. When temperature goes up, arterioles dilate. Now, why does that make sense? Because a busy tissue, a tissue that's using a bunch of oxygen and nutrients, is going to create heat, right? So it means if a tissue is hot, it's been busy. And if it's been busy, it needs more blood flow, right? Now, pH. The busier a tissue is, the lower the pH. Remember, we're acid producers. So when our cells are busy doing metabolic work, they produce acid. Acid lowers the pH. When the pH goes down, the arterioles dilate. That allows more blood into that capillary, right? And more blood into that capillary bed supplies that busy tissue, helps the pH go back up, right? So it's a feedback mechanism. Oxygen. When oxygen levels are low, arterioles dilate. Again, if you've got a busy tissue, It's consuming oxygen. The more oxygen it consumes, the more oxygen it needs. Well, if the oxygen in an area of tissue goes down, the body wants to put more blood flow there. So arterioles dilate. CO2, you can imagine it's opposite oxygen, right? As CO2 levels go up, arterioles dilate, allowing more blood to flow through. So this one fact, which is called autoregulation, all right, that arterioles respond to temperature, pH, oxygen, and CO2. This is really the fundamental of how our cardiovascular system functions. And so it goes like this. As long as the heart is producing cardiac output and the vessels have some vasoconstriction to generate blood pressure, as long as you have those two things, all the arterioles have to do is open and they get as much blood flow as they want, right? So it means that the business end, the delivery end of the cardiovascular system is controlled by the tissues that are busy, right? So as long as the body maintains a blood pressure, and we'll talk about how that happens in the next week or so, then there's plenty of blood flow for the tissues that need it, okay? So we've got all these tissues. They cannot all be busy at the same time, right? In other words, if we opened all of our capillary beds, we would need a cardiac output 30 times greater than what we do at rest. That is impossible. So it means that we can only open so many capillary beds at once. Now, thankfully, we don't have to do any conscious control of this, or what a mess that would be. The body handles this for us, So in periods of extreme exercise, when most of your muscle capillary beds are open, your GI tract, for example, the capillary beds there are turned way down, right? So you're not really digesting while you're sprinting, right? Instead, all that blood flow is going to your skeletal muscle. So the cardiac output, in other words, the amount of blood that leaves the heart, it is the only source of pressure in this whole system. So there's only one pump. So all of the blood flowing through all of the vessels at any given time has to equal the cardiac output. So the cardiac output is not determining where blood is flowing. The arterioles are determining that based on temperature, pH, oxygen, and CO2. Okay, so this is what I like to call autoregulation. Okay, so if we got to have blood pressure to make this work, it means that arterial pressure is the thing the body's constantly defending, all right? And this fits our clinical experience. In the normal healthy person, blood pressure stays remarkably constant regardless of what body position we're in, what level of activity we have. So the body is maintaining this arterial pressure where it wants it. How does it do that? How does it detect that? Baroreceptors. We talked about a couple of those. Carotid sinus, aortic sinus in particular, actually sense the amount of blood pressure that's present there and then adjust the sympathetic nervous system's outflow to control vasoconstriction as well as cardiac output by controlling heart rate, by controlling contractility, how vigorously the heart contracts. So contractile strength, venoconstriction, and total peripheral resistance, all of those things work to keep a blood pressure, all right? And then autoregulation steers that blood pressure into the blood flow that's needed wherever the body needs it. Now, the last manager of this system is the kidney. You wouldn't think that, but in order to have an effective cardiovascular system, we have to have enough blood volume to actually make this whole thing work. The kidney is the manager of blood volume. In other words, how much blood do you actually have circulating at any given time? The kidney is going to determine that, all right? So the kidney decides the volume. The sympathetic nervous system determines the level of total peripheral resistance, and the sympathetic and parasympathetic together determine the cardiac output. So with those three characteristics, or those three variables, we are able to control all that we need to in the cardiovascular system, right? And we'll be putting these pieces together over the next 2 weeks, not all before this exam, but we'll continue into after in our cardiovascular regulation section. All right, so if we're going to understand how blood flow is controlled by tissues, we need to do a little tiny bit of physics refresher, all right? So we have pressure and resistance. And if this sounds a little bit like electricity and resistance, if you remember that stuff instead, exact same rules, all right? But what we have here at the bottom is a pipe. If we're going to get fluid to flow through a pipe, we need to have a difference in pressure at one end of the pipe than the other end of the pipe, right? We call that a pressure gradient. In other words, high pressure on one side, low pressure on another. That's going to drive flow, the movement of fluid from the high pressure zone to the low pressure zone. Now, we have to introduce resistance. No pipe is perfectly smooth, all right? So that means that as a fluid moves through the pipe, it's dragging on the walls, okay? That drag is slowing it down, resisting its flow. So if we have a pressure gradient, that's going to make blood move. Resistance is going to tend to stop that blood from moving, all right? Now, there's a number of things that play a role in resistance, okay? In other words, what is the restriction to blood flow through a pipe? One is length of the pipe, all right? So the longer the pipe, the greater the resistance. Remember when you were a kid and you took 2 or 3 drinking straws and you stuck them all together? Then you tried to drink from across the room and it was a lot harder than you thought, right? It's because of this property. The longer the tube, the greater the resistance. Now, in our bodies, length of vessels does not change, or at least doesn't change very fast. In other words, the distance from your nose to your big toe is not a variable, right? It's not going to change once you're grown up. And even when you're a child growing, that changes really slow, right? So we can effectively ignore it. It matters, like the resistance is playing a role, but because it doesn't change, we kind of put it in the bucket of things that don't change, okay? So that's one characteristic, length. Smoothness is another. If I have a pipe with really rough walls, I'm going to have more resistance than a pipe with really smooth walls would have. Now, here again, does our body have varying degrees of smoothness? Yeah, but it doesn't change very fast. So even though smoothness plays a role in resistance, we can effectively ignore it because it doesn't change very much. Viscosity. This is not about the pipe, this is about what's in the pipe. So if you think of acetone or nail polish remover, okay, compared to corn syrup, right? They have a different viscosity. They're thicker. You know, the corn syrup takes forever to pour. The acetone pours and splashes all over the place, right? So the greater the viscosity of the fluid, the greater the resistance. Now, this doesn't typically play a role in our cardiovascular system because blood has a constant viscosity, you know, and it doesn't change much. Now, this is one where I can give you an example of where it does change. There's a disorder called polycythemia vera, where people end up with way too many red cells in their blood than they should have. Well, people with that disorder, they actually have higher resistance to blood flow and can end up with high blood pressure because the viscosity of their blood is significantly greater. Nothing else has changed, but they end up with a high resistance system. Now, most of the time in most of the examples, though, viscosity, just like smoothness and length, is not something that's going to change in our patients, okay? The other one that doesn't matter much is the number of branches or irregularities. So like if you look at the descending aorta, for example, it doesn't have a bunch of branches. So flow through that pipe is nice and smooth, low resistance. If you compare that to some of the vessels that you've now seen in the upper extremity, where they have 157 different branches, well, resistance in that vessel is going to be higher because it has more paths, right? It's less smooth. Another place that we see this play a role is in the brain, where you've got a lot of relatively large vessels in a small space, and all the branches actually increase resistance. But just like length, smoothness, and viscosity, the number of branches doesn't change over minutes to hours, right? It's kind of a fixed case for a particular individual at a particular time. So, length, smoothness, viscosity, and number of branches all affect resistance, but they don't change in the minutes to hours, so we can kind of put them all in one bucket. All right, so is there anything that does change in seconds to minutes to hours? Yes, and that's vessel diameter, okay? So, what does change is the size of vessels. Arteries have a ton of smooth muscle in them. When they constrict, their diameter decreases. When they relax, their diameter increases. So we have this physics rule that says that the resistance in a pipe changes by the third power of the changes in the diameter. So what that means is if we go from a diameter of 1 to a diameter of 2, our resistance goes down by 2 to the third, right? So we get a big change in blood flow for a small change in diameter. I can't stress how important this is enough, okay? Because this is how autoregulation works. When arterioles get bigger, the resistance of blood flow through that vessel goes down, and therefore the flow goes up. And that relationship isn't linear. It's not 1-to-1. It's to the third power. So if we double the size, like we go from D1 to D2, we get a 16-fold increase in blood flow, for example. All right? So it's the change in diameter or radius that is the primary controller of where blood flows in the body. Okay? Now, one more bit of characteristic about fluids and pipes. Fluids and pipes can move in two different ways. One is turbulent flow, okay? That's our example C. B is what we call laminar flow. In laminar flow, fluid is able to move with very little resistance from itself. In other words, the way I think about this is when blood is moving like B, it's not bumping into itself and therefore can flow with a lower amount of energy. If we look at example C, here we have blood that's kind of running into itself, and by doing so is increasing resistance. So another thing that causes an increase in resistance in our system is turbulence. We get turbulence from a couple of things. One, when the speed of blood in a pipe is too high for the resistance. Now, what does that mean in real life? If you've got a lot of blood going through a narrow artery, you're going to have resistance, right? Because you're trying to push too much stuff through one place. Another way of putting that is, if the tube is too small for the level of resistance or the velocity, we get turbulence. Obstruction, a sharp turn, rough surfaces. Now, where do we get this in the body? Sharp turns we get in the arterial system. And in regions where you have like a 90-degree branch, some of you have probably seen some of those in the anatomy lab, those are actually places where turbulence is quite high. And in those areas of the arterial system, more damage occurs in the walls of those vessels than in straight vessels because of the turbulence sort of eating away at the wall as it goes by. So we have a couple of different areas where our resistance increases due to turbulence. The resistance and diameter relationship, it's to the fourth power. I said to the third power. I had Poisson's law in my head instead. But it's to the fourth power. So if you increase the diameter of a tube by, if you double it, you get 16 times the flow through it. All right? Now, for those of you who are maybe not, math doesn't make intrinsic sense to you, what this is saying is that a very small change in diameter makes a very large change in both resistance and blood flow, okay? And that's essentially what we need in order to have the capillary beds, the arterioles, control where blood is flowing in the body. These are tiny, tiny little vessels, and they can't do very much, but they can dilate and constrict. So by dilating, they greatly reduce their resistance, and by doing so, much more blood flows through them. So it means that the arterioles act like the primary valves in the system that controls where blood is flowing at any given time. Okay? All right, let's knock out a few more of these. Now, I have hidden some slides. So just make a note of those as we go. Those are that's information that you're not going to need to look at, okay? All right, so we talked about diameter. Let's talk a little bit about resistance in series versus resistance in parallel. There's sometimes a little post-traumatic stress disorder about this from physics class, right? But just as a reminder, we're keeping it very simple. So if you have two areas of resistance like we have in our top in A here, the resistances add. So in other words, the resistance from this end of the pipe to this end is R1 plus R2. All right, all that means is you have to pass through all the resistance in the pipe before you can get from one end to the other. If you contrast that with a parallel circuit like this, where we're taking the pipe and we're splitting it into four smaller ones, it's the inverse. So again, some math here, but 1 over the total is the sum of the inverse of all of these. All right, that sounds like a lot of fancy math. What that means is parallel systems reduce resistance. Okay, that's what the physics means there. Series systems tend to increase the resistance. In our human physiology, we see a lot of parallel pathways because as we go from aorta out to capillary beds, we have put the blood through more and more paths. Well, by doing that, we've essentially dramatically lowered the resistance of blood flow through the body. This is a good thing. Remember, we only have one heart, and that heart can only do a limited amount of work. So by having our cardiovascular system exist in parallel, in other words, having lots of different pathways for blood to go through, we dramatically reduce the resistance. Now, the corollary or the flip side to that is we cannot have all of our pathways open at once. I've talked to you about that now a few times. If we had all of the capillaries open at the same time, we would have a truly massive parallel system, and we'd have almost no resistance to blood flow. Now, that sounds like a great idea, except that when you turn down resistance, you lose pressure. And it's blood pressure that drives blood around the body all the time. So if we take the blood pressure away, we don't have anything to move the blood, and our perfusion stops, right? In other words, tissues no longer receive adequate blood flow. We'll talk about that in clinical medicine as shock, when we have too many pathways for blood to flow through. Look, my clicker's not working. I have the worst trouble with that. There we go. All right, we talked about viscosity last time and the relationship of viscosity to resistance. And the thing I wanted to point out to you is viscosity is typically a constant for an individual, right? So I said because it doesn't change from minutes to hours, we can effectively ignore it, and that's true. The only time we can't ignore viscosity is if we have a hematocrit derangement. All right, so what's hematocrit? It's the ratio of blood cells to blood volume. All right, so like if you take blood out of a patient, it's a mixture of plasma and cells. If we spin the blood down, we squish all the cells down into the bottom. Well, the hematocrit is the percentage of cells to the percentage of the whole thing. So essentially what I'm saying here is if you are anemic, in other words, you have a relative deficiency of red blood cells, your blood is actually less viscous than it is in the normal. Less viscous blood can travel around the body with less resistance, right? So it means that when you have anemia, your blood flow is actually more brisk than it is in the normal case. Now, this helps you a little, but it doesn't fix the underlying problem, which is you don't have enough red cells. So you still have an oxygen carrying capacity problem, which we'll talk more about that later. Polycythemia is the reverse of anemia. This is where a patient has too many red blood cells. Their hematocrit is too high. In the case of polycythemia, the viscosity of the blood is actually above normal. And this causes a sort of sluggish blood flow problem where we have increased resistance to blood flow. It takes more energy to push the same amount of blood through the same pipes, right? So polycythemia, it's an interesting disorder because it doesn't really do much harm except for this whole viscosity business. The way we treat it is we send them to the blood bank, right? Because they just have they donate blood periodically. That lowers their hematocrit, which lowers their viscosity. Easy enough thing to treat. Now, of course, you do have to figure out why they're polycythemic before you go down that path. But this is just showing you that as the hematocrit increases, in other words, as you get more and more red cells in the blood, the viscosity increases. And as we talked about yesterday, as viscosity goes up, resistance goes up, right? So we need more pressure to drive the same amount of blood around the body. All right, we finally get to a Kahoot. So we'll join after I've hit start, all right? The numbers always appears on the screen somewhere. Okay, so thick walls, fast blood flow, high pressure. Which vessels are these? So 9964509 if you're still waiting to get in. All right, very good. Almost all of you got that. That's arteries. That's their job. Their job is to conduct high pressure, high velocity blood from the heart out to the tissues. And one of the reasons that it evolved that way is, speed does matter. The faster you get the blood from the lungs to the tissues, the less oxygen that blood has lost, right? So velocity does help us here. All right, honest squid with the early lead. These vessels contain 2/3 of the circulating blood volume at rest. Some of you have been studying. That's right on. Haha, okay. People always get these two confused. All right. The capillaries. We have more capillaries than we have of any other vessel, but they're super tiny, okay? So it means that at any given time, most, i.e. 2/3, of the circulating blood is in the veins, okay? And the reason for that is, number one, we have a lot of veins, and number two, they get to be pretty good sized, right? Compared to the arteries that travel with them, veins are about twice the size of the arteries if you look at lumen size. So The reason that this is important is it means that most of the blood's in the venous system at any given time. If we make the venous system smaller, which we can do because veins can constrict, we call that venoconstriction. If we reduce the volume of the venous system, it means that some of this 2/3 we push into another compartment. And where we push it to is into the circulating capillary beds, the capillary beds that are open. So like during a period of exercise, for example, you don't have 2/3 of your blood in the veins because you've had venoconstriction, and the blood you've pushed out of the veins is now filling up the capillary beds in your muscles, right, in your skeletal muscles. All right, honest squid holding on to the lead. All right, velocity is slowest in which of these? Slowest in the capillaries. Why? Because there's more of them than anything else. The analogy I usually use here is a river. You know, like if you take a river flowing through a canyon, in other words, it's bound on both sides, it flows really fast, right? That's where you're having fun on the Whitewater Rapids. Well, if that same river opens up into a big valley, the speed of the river slows way down. That's what's happening in the capillary beds. We're taking the blood from the heart and we're putting it into lots and lots of different vessels, so the velocity drops way down. So the capillaries have the slowest blood flow of any area of the body. But don't think that that means they have the lowest pressure. Okay, they don't. The lowest pressure in the body is at the end of the venous system, okay, at the right atrium, like we'll talk more about today. All right. Tissue has a pH of 6.5, a PO2 of 10, and a temperature of 101 degrees. All right, pH of 6.5 is low, PO2 of 10 is really, really low, temperature of 101 is high. What will happen? All right, very good. The arterioles are going to dilate. All right, this is the fundamental here of autoregulation. That in a region, in a tissue that has chemical signs of being busy, in other words, a low pH, a low PO2, a high PCO2, which isn't on there, and a high temperature, all of those cause the arterioles to dilate. When they dilate, they allow more blood flow through the capillaries. That more blood flow brings, washes away the pH, the hydrogen ions. It brings more oxygen, and it causes cooling, right? So this is autoregulation. The arterioles open in response to signs of a busy tissue. Now, some of you put the cardiac output will increase. That's true at the organismal level, all right? So like I'm saying a tissue has a pH of this, that, and the other thing. If the whole organism, if Skinny had a pH of 6.5, yes, his cardiac output is going to increase, but that's not at the tissue level, that's at the organism level. And frankly, we haven't gotten there yet, okay? But I'm talking about autoregulation. Okay, big streak there. All right, last one. Which of these does not increase resistance to flow in a tube? Okay, so longer tube, yes, higher resistance. Smaller diameter, big, much higher resistance, right? It's to the fourth power. More viscosity we talked about. An increased pressure gradient, as long as the tube isn't too small, increasing the pressure gradient just makes blood flow faster. It doesn't increase the resistance, okay? Correct answer there, increased pressure gradient. All right, we'll see who is the winner, Power Condor. Nicely done.